Now, moving from pre-hospital management to the hospital management, which is actually the paramount of trauma care. We'll be briefly discussing what is organization and primary survey, what is airway and cervical spine control, other adjuncts to the primary survey. So coming to the hospital management, the most important point is organization of trauma centers. We need to develop, equip and train the people in the trauma center so that they can provide effective trauma care. Trauma teams needs to be made, which should be trained well enough to assess and manage the trauma care. Once the initial assessment and management has been done, they can either refer to the definitive care for the same hospital if it is a level 1 trauma center, or they should be equipped enough and trained well enough that they can refer the patient to the definitive care facility if needed. Now coming to the organization. Now usually there are receiving hospitals which may not be able to take any trauma, but we have to be labeled as well. Then there could be simple trauma units which actually are able to manage a single system trauma, not immediately life-threatening, which are usually level 2 trauma, but they cannot provide a definitive care. So once the patient is stabilized, the patient is shifted to the level 1 trauma care center, which is actually the major trauma centers, which are large regional hospitals, manage all level of polytrauma with relevant specialties available. For example, the patient is having orthopedic injuries, they will have an orthopedic as well, and head and injury, they will have a neurosurgery department as well. So they can, once the patient is stabilized, the patient of polytrauma, then the relevant departments can be called in to manage the different aspects of the trauma. Now coming to the ATLS concept, that is advanced trauma life support system concept. In case if it's a compound fracture usually means a comminuted open fracture. The 3-stage approach is actually needed. The 3-stage approach is needed is in primary survey and simultaneous resuscitation. As I told you, the resuscitation and evaluation goes hand in hand. You do not evaluate the patient then start resuscitation. You evaluate, you resuscitate, you evaluate again, resuscitate, you evaluate again and resuscitate again. This is how the process goes on. So first is the primary survey along with the adjuncts, and then the simultaneous resuscitation, then which includes rapid assessment and treatment of life-threatening injuries. Then it is actually the secondary survey along with the adjuncts, which actually detail head-to-toe evaluation for identify all other injuries which may not be life-threatening but may eventually or potentially maybe become life-threatening later on. And then it is a definitive care. This is actually kind of specialized treatment of the identified injuries. Now, how to actually, this algorithm is very important to assess what is the initial assessment and management. That is, if you have an injury over here, the patient is brought by the EMS to the hospital, you start with the primary survey. Primary survey is again the ABC, that you say airway and cervical spine. Then you look at the breathing, circulation and disability along with the adjuncts, and then you continue the resuscitate as you continue to evaluate. Once you're resuscitating, then you are also re-evaluating at the same time. And if it's actually after evaluation the patient is becoming stable, you move to secondary survey. And during secondary survey, at any moment the patient becomes unstable, you re-evaluate and resuscitate. And if patient has become stable, then you continue. If patient remains stable, you continue to do the secondary survey. After re-evaluation, then you go for the transfer end of to the definitive care. This is how it happens, that you evaluate the patient along once you are also making the patient stable at the same time. If at any time the patient becomes unstable, you re-evaluate, resuscitate and again make the patient stable before moving on to the secondary survey. Now coming to adjuncts to the primary survey. What are the adjuncts after performing of the primary survey? As I told you, primary survey means airway, breathing, cervical spine. Then other adjuncts which needs to be performed include vital signs and ECG, pulse oximetry to check whether the ventilation is proper or not. The end-tidal carbon dioxide level is important so that the patient is breathing properly or not. Then ABGs to assess whether the patient is having any acidosis or alkalosis, secondary to other problems as well. Urine output, that is actually indicates whether the resuscitation has been adequate or not. So to measure urine output, you need to put in a urinary catheter. Our nasogastric tubes are usually done unless contraindicated, but with the base of skull fractures you need stomach decompression so that the patient does not aspirate. And part of the primary survey along with adjuncts is actually the chest x-ray and the pelvic x-ray, which are the two mandatory x-rays which must be done during the primary survey to evaluate the patient for life-threatening injuries, for example pneumothorax, hemothorax and pelvic trauma. Now coming to the primary survey and resuscitation. Awareness recognition management ARM system is actually applied. Patient is simply awareness means head injury, which is most likely to cause unconsciousness. Then obstructed airway is usually could be another cause which is affect the awareness of the patient. That coma alerts practitioners to change chances of airway obstruction. This is very important. The patient is not conscious. There could be a problem with the head injury or there could be an airway compromise. Then is the recognition. This obstructed airway is important, whether patient is having noisy breathing or snoring or the chest is not expanding properly, then there may be a problem, a trachea is shifted, or there is associated with facial trauma or oropharyngeal trauma. Then we must be expecting if there is a laryngeal trauma as well, then there may be patient may have an airway compromised. But that can be done by looking, listening, feeling for the diagnostic signs. Then management includes airway established with simple bare hand maneuver, that is chin lift and jaw thrust. Airway adjuncts can be done to make sure that all the patient is stable enough. And then advanced airway intervention such as ECT may also be needed. Now coming to the airway and cervical spine control, that is the A of the primary survey. There are two techniques: manual inline immobilization, as you can appreciate it over here, that actually cervical spine is kept straight. Other option is you cannot keep it forever, so to relieve that EMS man out of the misery, the other option is once the patient cervical collar is applied, this patient can take his hand out, so that because now after cervical collar the cervical spine will remain straight or in traction. Then is the airway examination. Airway examination starts with listening and feeling for the signs like respiratory distress or decreased conscious level, secretions and blood which may be suctioned. Then oropharyngeal and nasopharyngeal airway is actually basically put. The first is you do the chin lift, jaw thrust, you take out from all the oral cavity, all the secretions are actually taken out, and then you put in an oropharyngeal tube or nasopharyngeal tube, and then you go for passing of ETT. Then hold tongue forward. Now comes after ETT has been passed, airway has been secured, then we come to the breathing problem. Breathing can be examined by listening and feeling of the chest cavity. Look for the adequate symmetrical excursion or expansion of the chest. Bruising or open wounds or tachypnea. If there is any of the signs, then patient may have compromised breathing. Or abnormal or absent breath sound. Absent breath sound is the classical with hyperresonant node, means the patient has a pneumothorax. So this is actually examination of the chest mainly to look for it, feel for it, and percuss and auscultate of the problems which may be possible in this case. If the trachea is actually palpated, to detect whether the trachea is deviated or not. And if it's deviated with absent breath sounds on the other side, and that actually means the patient is probably having a tension pneumothorax. Deviation is usually done, as I told you, by tension pneumothorax. This could be due to surgical emphysema as well. And tension pneumothorax is a serious emergency which has to be treated immediately. The initial step is to pass a large wide bore cannula in the second costal space to relieve at least some part of the tension pneumothorax, and then to immediately pass the chest tube. Then decompression with large bore cannula, as I just told you, and then in second or fifth intercostal space, this is basically the passing of chest tube or tube thoracostomy has to be done. Ventilation is by a BVM assembly or bivalve method as well. Now once we are done with airway and breathing, then we shift to the circulation. We have already talked about the circulation is that we compress the bleeding points, we give fluids, we give blood to the patients, and if we are unable to stop the bleeding, then we may have to apply tourniquet for the time being as well. From airway, breathing, circulation, then comes the disability. Disability can be judged by use of a Glasgow Coma score or GCS. It's basically records three things: records eye opening, records best motor and verbal responses. On average, it's between 3 to 15. The best is the 15, are absolutely normal, and 3 is patient is dead. And the duration, the conscious level can be actually directly determined by the duration, the GCS level, and we need for elective intubation and ventilation as well. The pitfall of intoxication is that it should be always considered. For example, the patient may not have a trauma, but patient may be drugged, or patient may have alcoholic intoxication, and patient may be drowsing not due to trauma but due to the alcoholic intoxication. So that has to be taken into account as well, that why the patient GCS is down. Is this due to airway compromise or something else, or is it due to intoxication as well? Pupil examination is part of the basically primary survey, and if there's an abnormality in them, then probably the patient has a raised intracranial pressure as well. Unresponsive pupils indicate serious brain damage, so that is very important that the pupils are actually, if there's sluggish contraction, there may be raised SCP. If they're not contracting to light, then probably severe brain damage has occurred already. Now this is how the score of GCS is. This is total score I told you is 15, 4 for eyes, best motor response is 6, and best verbal response is 5. So this is how it is. If the patient spontaneously has opened the eyes, then it's 4. If you ask and command the patient to open the eyes and he or she opens it, then it's 3. If you on pressing the temporal area of the eye or orbital area of the eye, the patient opens the eyes on pain, that is 2, and this patient does not open despite giving pressure on the eyeballs, then it is probably 1. Similarly, if it obeys command, you ask to him or her to lift his or her hand or leg, that is 6. Localizes pain, it's 5. Normal flexes is 4. Abnormal flexes is 3. Extensive response is 2, and if there is no response at all, then it's 1. Verbal, if the patient is oriented, that is 5. Confused, that is 4. If the patient is mumbling words but actually do not make sense, not complete sentences, then it's 3. But if the patient is only moans, making moans and groans, and there's no actually only sounds, it's not words, then it's 2. And if there is no verbal response, then it's 1. That is how you expose. Then important is, after you've done with A, B, C, and D, then comes the E, and E stands for exposure and the environment. That is, you remove the clothing. Why that is important? Because sometimes there may be chemicals which will be present on the clothing, which may be irritating the skin and burning the skin, so that all has to be removed as well. Plus, we have to make it sure the control of the environment as well, that the patient should not undergo hypothermia. And once we have removed the clothes, we can examine full examination of the entire body, from the back, from the front as well, so that there are other associated injuries or not. Now that requires a log rolling. While log rolling is done to protect spine. So that is how it is done. You log roll the patient, you examine the posterior aspects. The cavity has to be kept warm. Hypothermia increases the mortality. And hypothermia means peripheral shutdown and patient becomes acidotic. Eventually, severe hypothermia may have 100% mortality. Now, once we've done the primary survey, that if you've done A, B, C, D, and E, then come the adjuncts to the primary survey, which may be required to further evaluate the patient. Once the patient is stable, we can go for ECG, which monitors heart rate, detect arrhythmias, ischemic changes, and all that. We can go for pulse oximetry, which may use saturation of oxygen, monitors peripheral tissue perfusion, unreliable, low output in states. Sometimes it's maybe low because of the hypovolemia, but we have to take into account what is the possible problem which can occur along with the pulse oximetry. Now coming to the palpable pulses, the different blood pressures we need to. Sometimes the patient not be conscious enough to tell you what happened, but if the patient, you can feel the carotid, femoral, radial, then probably the systolic pressure is greater than 80. If the carotid and femoral only can be palpable, then it's greater than 70. If it's only carotid, then 60, and if there is no pulse, probably the systolic pressure is below 60. Now further coming on to the adjuncts, actually ABGs are also done. This is to actually estimation of arterial carbon dioxide partial pressure. In intubated ventilation patient, end tidal carbon dioxide monitoring is very important. and then allows optimization of the lung ventilation because the patient is actually on the ventilator, then confirms tracheal intubation and alerts preeclampsia too if there is a drop in the cardiac output as well. And this is how actually it's done through a nasal prone, and they actually measure the end tidal carbon dioxide, which is actually the patient is exhaling out. Now coming to the ABGs. ABGs allow quantification of the arterial oxygen, carbon dioxide, partial pressures can be measured, and usually acid-base imbalance can be corrected, and gives HP, sodium, potassium, and glucose levels as well. Why urethral catheter is important? Because it measurement of early urine output. Unless insertion is contraindicated, for example, there was urethral injury, then we may have to go for suprapubic catheterization rather than intraurethral catheterization. But usually, it's basically the one of the primary adjunct and must be urinary cath must be passed in trauma patient, or as I told you, it could be in a case of ruptured bladder or in urethral injury. But what happens is, in case of hypotensive shock, urine output is actually a measurement of your resuscitation, that how much the patient is still in shock or still actually responding to shock or not. Other adjuncts to primary survey include nasogastric tube, which is helpful in decompression of stomach, helps prevent aspiration. Unless insertion is contraindicated, it should be passed in every trauma patient. Usually, in case of base of skull fracture, there is actually stomach gastric dilatation, so there is increased chance of aspiration. Therefore, NG must be passed. Chest X-rays and pelvic X-rays are actually used to diagnose pneumothorax, hemothorax, and contusions and other rib fractures as well, are one of the very important in primary survey. Then pelvic X-rays, these chest X-ray and pelvic X-ray are a part of the primary survey because usually with the pelvic injury, especially the fractures, there is specific venous bleeding which could be massive. The patient may lose up to 2 to 2.3 liters of the blood at times. Therefore, this can cause massive hemorrhagic shock. Therefore, pelvic X-ray is of utmost importance in primary survey. As in this section, I have told you what is the hospital management. It's again the primary survey starts with the airway and cervical spine. Airway is first secured, and then the cervical spine is immobilized by use of cervical collar. Once that is done, we go for the breathing. That is, we assess the patient for breathing difficulties, for pneumothorax, hemothorax, or multiple rib fractures. Once we are done with that, if tube thoracostomy is needed, that is passed. And once the breathing is corrected, then we move to circulation. Circulation can be corrected by use of first applying pressure on the wound to control bleeding. This could be in form of tight dressings, could use with tourniquet. Then we give fluids to replace the hemorrhagic shock, and then blood may also be required as well. Once the circulation is stabilized, then we move towards the disability. That is the neurological assessment of the patient by use of GCS. If the GCS is done and the pupils are actually checked to rule out any base of skull injury or neurological injury, then after that we move to the E, that is the exposure and environmental control. Then patient must be exposed wholly to see of other injuries, as well as patient must be prevented from going into hypothermia. And once we are done with this primary survey, we move to its adjuncts such as ECG, urinary catheterization, measurement of early output, vitals, chest X-ray, pelvic X-rays, and use of NG intubation as well. Thank you very much. Keep watching sqadia.com.